Hello, my name is Jodeline Morales. I am a student at Berea College majoring in Health and Human Performance. This video is made for Michelle Thornton's class HHP 247 Team Sports. In this video, we will talk about rotator cuff injuries, but more specifically, a rotator cuff strain. We will have a pseudo patient for the purpose of this video, which we'll be able to treat with the SOAP method. Let's begin our discussion with what exactly a rotator cuff strain is. So a strain is commonly known as a pulled muscle. The strain can be classified on a scale of 1 to 3, where grade 1 is only a small number of fibers are torn, resulting in pain. 2, partial tear, where a substantial number of muscle fibers are torn. There is slight loss of muscle function and movement here. Or grade 3, which is a complete tear. All muscle fibers are ruptured, and there is complete loss of muscle function and movement. To further understand this injury, we will review some shoulder anatomy. The rotator cuff is composed of 4 different muscles: the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. An easy way to remember this is the acronym SITS. Each muscle are as follows. The supraspinatus is responsible for abducting the arm. The infraspinatus is responsible for externally rotating the arm. The teres minor is responsible for also externally rotating the arm. And the subscapularis is responsible for internal rotation, adduction of the arm, and stability. Refocusing on our injury, the symptoms begin as a sharp or burning pain. It's usually concentrated in and around the specific area. This location depends on the affected muscle. If the injury progresses and is left untreated, pain can travel to mid-back and neck. Movements that can cause pain include lifting, pushing, and pulling. Major causes of this injury include trauma, overuse, weakness, poor posture, and faulty movement pattern. A strain can also be a result of impingement syndrome, which is shoulder pain caused by connective tissue or a tendon rubbing on a shoulder blade. Now let's move on to our patient. So our patient is Cameron Sagozin, who is a 27-year-old female. She represents her city in a California statewide competition. She works out all of the time, and she is very proud of her left back position where she is able to shoot from a long range, and she uses a lot of shoulder power. Now that we have introduced our pseudo patient, we will be able to overlook the SOAP method. S stands for subjective, which is self-reported sensations or feelings. O for objective, which are reliably measurable or observable details. Then we have assessment, in which the main problem is identified and we prioritize it in order to create goals. And lastly, we have plan, which is what will be done in order to recover or continue recovering the injured person. As we recently learned, Cameron represents her city in a statewide competition. She is very serious about this. She has been working out and conditioning, but she recently increased her weight during her workouts and her practice has been a little more intense than usual. During the first 2 weeks, she felt oddly sore, but she did not ice and she did not rest. The following 2 weeks, Cameron feels pain mostly when she makes an overhead throw, and she feels pain specifically in the area above her shoulder. Despite the discomfort in the condition, she still does not rest and she does not ice. 2 weeks after that, she begins to feel a weakness in her throwing arm, and she feels a clicking every time she does an overhead motion. Cameron says that she has felt pain in her shoulder before, so she decided to leave the area untreated. After collecting our pseudo-patient's history, we are able to move on to the objective portion of the SOAP method. For our observations, we saw some swelling all around her shoulder. For palpation, the patient was point tender under the superior side of the glenohumeral joint, or simply above the shoulder area. We then asked Cameron to perform abduction of the arm, adduction, flexion, extension, internal rotation at neutral position, and external rotation. She did these actively, passively, and we tested them once again with the manual muscle testing. For the active range of motion results, we saw that abduction was limited with pain. Adduction was full. Flexion was also full, but there was some pain. Extension was full. Internal rotation was full. And external rotation was full with some pain. As for passive range of motion, we still saw the limited range of motion in abduction with pain. For adduction, there was full range of motion. Flexion was full. Extension was full. Internal rotation was full. And external rotation was full with some pain. For manual muscle testing, abduction received 4 out of 5. Adduction was 5 out of 5 with some pain. Flexion was 5 out of 5 with pain. Extension was 5 out of 5. Internal rotation was 5 out of 5. And external rotation was 5 out of 5 with some pain. It is important to note that this 5-scale range for the manual muscle testing is to simply observe the discrepancies between our good arm and our bad arm in terms of muscle. After collecting this information from our patient, we are able to further examine the areas that we have particular questions about. This will bring us to the assessment portion of the SOAP method. For our assessment, we decided to test her for the Jobs or empty can test. This test requires the patient to be standing or sitting upright. Their arm should be anteriorly flexed at the level of the shoulder. The patient will fully pronate the arm into the empty can position with the thumb pointing downward. Then the patient should resist the downward force being applied on the forearm by the examiner. You can see that especially in this picture as the examiner behind the patient is pushing down on her arms. Pain or weakness indicates a supraspinatus tendon lesion, which is what we were looking for based on our test results from the objective portion. These results do not necessarily give us a positive empty can test, as a positive empty can test would indicate a complete tear in the muscle being tested. Based on our assessment, we are able to provide treatment goals. Our treatment goals for this patient will be inflammation and pain management, flexibility of the shoulder joint, and we will then strengthen once the pain relieves. After fully assessing our patient, we are able to come up with a plan. We will provide NSAIDs to provide pain relief. We will then use the RICE method, which is rest, ice, compress, and elevate. We will also complete flexibility exercises and encourage free movement of the shoulder joint. In order for Cameron to see better results, she will need to do rehabilitation rather than doing practice. We are now able to move on to the treatment plan in detail. Cameron will begin her rehab plan by doing pendulum swings. She will do this for 1 to 2 minutes. She will lean over, bending at her hips, and she will use a tabletop for support. She will then continue to perform easy movements with her arm in all directions. If the movement is too easy, a light weight may be added to provide gentle traction. The next exercise is flexion stretch. She will clasp her hands or hold on to a cane or broomstick. She will keep her knees bent and stretch her arms overhead. She will repeat this stretch 10 times. The next exercise is abduction range of motion. She will begin by lying supine on the floor, arms fully extended against the body. She will then abduct the arm away from her body by walking it with her fingers. She will abduct it to the point at which she feels a gentle stretch. She will then hold it for 10 seconds. She will continue to abduct her arm until another stretch position is reached, and again hold it for 10 seconds. She will continue this progression until her arm abducts at 90 degrees. Progression for greater range of motion can be made after 2 weeks of reaching 90 degrees of extension. After performing range of motion exercises, Cameron will then move on to strengthening exercises. She will begin with shoulder flexion. For this exercise, she will stand with her arm at the side with her elbow fully extended. She will then raise her arm up in front of the body until it is parallel with the floor. She will then hold this position for 1 to 2 seconds and slowly return the arm to its starting position. She will do this exercise about 10 times. The next exercise is shoulder abduction. She will stand with her arms at her side and her elbow fully extended. She will then abduct the arm away from the side of the body until it is parallel with the floor. She will hold this position for 1 to 2 seconds and slowly return to its starting position. The last exercise that Cameron will perform is a variation of the abduction diagonal pattern. She will begin by laying down and her arm extended with her hand turned inwards. She will then progress to move her arm in a diagonal fashion until it is parallel with the ground. As for incorporating components of the Rice method, Cameron is expected to rest instead of practice for the next week, and she will ice after every rehabilitation session. After this rehab protocol is complete, we hope that Cameron will be able to return to her handball game and be the first in the California state competition. This concludes my presentation on rotator cuff strains, and here are my sources. Thank you.